live now, guys.
Yay!
So thank you everyone for attending today's talk. We're going to be discussing the uses of data in patient care. I am Kimberly Diaz and I am the moderator for today's event. And we are joined by Dr. Kate Dressbach and Amber Lee, who are two fabulous women in data that I've known for a couple years. And so thank you everyone for coming to our webinar today. And we hope that you're engaging and that we give you some good information and that you continue on if you want to the networking event that's going to be held right after that. So let's get started, ladies, with some basic introductions. Amber, would you like to go first?
Sure. So my name is Amber Lee. Right now I do HIV surveillance for the state of Maryland. So my specialty is HIV, infectious diseases. And because of that, I'm now working in the COVID space and I'm kind of balancing HIV and COVID-19 work. So yes, a lot of state health departments, I do that. Before that, I was doing a lot of federal government work. And so I kind of go back and forth between the two. And that's me. So thank you for having me.
Dr. Dressbach.
Thank you. So hi, everyone. I'm so thrilled to be on this panel today, not just to be alongside these two amazing women, but also to continue to share in the enthusiasm and energy of TomTom. As you heard, my name is Kate, and I live in New York City, and I'm currently a postdoctoral research scientist at Columbia University in New York. We can talk all about what it's like to move to New York City during the pandemic in the networking lounge if you want to hear more about that story. But I just finished my PhD this last spring from UVA, where I'm also a 2018 alum of the Masters in Data Science program. When I left UVA in May, I had also been a nurse for almost 7 years clinically at UVA Medical Center between labor and delivery, postpartum, and the neonatal intensive care unit. But because of my clinical background, I'm really interested in how we can design tools at the bedside to amplify the patient's voice and experience. So my postdoc project is on cardiotocography, or monitoring baby and mother during the labor and delivery process.
Fantastic. Thank you, Kate. And I am Kimberly Diaz. I got a couple different hats I'm wearing right now, some new ones I've just put on. I'm really excited. So I'll start with probably one of the more important things I got going on is that I'm a PhD student in health informatics at Rutgers University. Have a very fantastic experience there. So if you're looking for a program in health informatics, I strongly encourage you to consider Rutgers. Unfortunately, they no longer have the PhD, but they do have a master's in health informatics. The faculty are great and very supportive. I am currently at the dissertation stage. And so right now I am doing number crunching, which is a lot. And my project is looking at improving health outcomes of Black women living with HIV using machine learning. So there's a lot of statistics, and I'm able to use a lot of techniques I've picked up being a health informaticist and data scientist. So that's that hat. One of the newer hats I'm wearing is that I'm a TA for Correlation One, and that is a kind of boot camp type setup for folks who want to learn about data science. This is my first time teaching, and so ultimately what I hope to do with my PhD is become a professor, an adjunct professor, work part-time, work towards getting more women and more diverse representation in the field of data science and health informatics. And then finally, the third hat is I am a chemical informaticist, and I'll be working at an organization called the United States Pharmacopoeia starting next month. So just to back up a little bit, I am formally trained as a chemist. And my first job out of graduate school from UNC Chapel Hill was at United States Pharmacopoeia. So for me, this is kind of going back home and I'm really looking forward to it. So I'm combining my chemistry hat with my informatics hat and going to work to improve some of the things that they're working on in terms of medical and drug vocabularies and providing standards for organizations to use when they're naming drugs and discovering drugs and all that. So those are my three hats, and that's my brief introduction. And so now you guys, ladies, want to talk about how you got into the field. I kind of hit it on it a little bit, so I guess I'll continue. So I originally was a chemist. I worked at the bench for a number of years. I relocated to the DC area. And then after I worked at USP for a couple of years, my father at the time was diagnosed with terminal prostate and colon cancer. And so I ended up going to the National Cancer Institute, and that's where I kind of got really involved with doing cancer research. So initially in epidemiology, and then I missed being at the bench, and then I went to pathology and did a lot of cancer oncology biomarker work there. And it was a really great time, but I started to recognize that without a PhD, at least in a general science, it would be really difficult to advance and move ahead. But I also knew that I didn't want to get like a biochemistry PhD or anything like that. So I started thinking about what I wanted to do. And because I'd done a lot in biomarker work, a lot of that involved bioinformatics. And so that's how I initially got into the field, was actually through a back door, so to speak, through bioinformatics. So that's kind of a little bit about my beginning. Kate or Amber, you want to jump in and talk about how you got involved in data?
Go for it, Amber.
Sure. Okay. Well, my story is it's all over the place and it's a long story. And I often start by saying, how much time do you have? Because you get the short version or the long version. I went into undergrad wanting to be a foreign diplomat. And so I studied global affairs, and I concentrated, I speak Spanish and Japanese. And I was thinking, okay, I'm going to take those two and I'm going to be a diplomat and, take over the world, right? 2 years into the coursework, I realized how much I hated it, and my hatred for it ran deep. It was the coursework, the theory, just everything about it was, I knew that I was not supposed to be there. So rewind to my childhood, I was always someone who was interested in researching diseases and looking into which populations are affected by certain diseases, right? I was always interested in that. I was homeschooled. I couldn't watch TV on the weekdays. So that was kind of like my fun, looking at disease in encyclopedias and, that kind of thing. That's what I did for fun. So I didn't know that there was actual, a way to study that. I didn't know that, epi was a thing. I knew nothing about it until I think maybe my third year in university. And I stumbled upon public health, and I was thinking, so maybe there's a way to still graduate on time and, still get my degree, but maybe concentrate on trying to kind of bridge the gap between public health and global affairs by studying global health. So, that worked. I managed to kind of split the difference, and I ended up interning with the U.S. Department of Health. And with their Office of Global Affairs, I ended up getting, an internship with the FDA, with their Office of Global Affairs. And I was really having fun kind of bridging the gap between public health and then a lot of global affairs work, global health, so to speak. So then graduation came up, my senior year was upon me, and I was thinking, okay, what's next? I knew that I wanted a more technical background, and I wanted a technical foundation within public health. So I was like, well, what's better than epi? Because I was taking public health courses, and I kind of had an idea of what epidemiology was. I was thinking, okay, I like data. I was good at statistics in high school. So I'm kind of trying to pivot from global affairs into a more STEM-based environment, right? So my thinking at the time was, okay, if I can apply and get into an epi program for grad school, if I can do well at that coursework, then maybe I'll have what it takes to get either a PhD or even an MD. At the time, I was bargaining with myself. It made sense at the time, so I did that. Got my MPH in epi from George Washington University, and they trained me very well for, a career in data science. Like, I really couldn't have asked for better training. And it took me some time to find a job, which, we can speak about the trauma of that some other time, but I ended up landing this position, and it'll be 2 years in January doing HIV surveillance. So super long-winded, but that's my story.
Sounds good. So you mentioned about public health. My mother was actually a public health nurse, so I kind of always had an epi flavor. And a lot of what I'd done getting to becoming a health informaticist and data scientist was actually through public health. And I imagine that's something that we all have in common. What about you, Kate? I know you've been a nurse, so I'm sure there's some public health flavor to your background as well.
Absolutely. And I think on a higher level, both of your stories remind me how I think, especially for women, we navigate into more technical careers in a more like curvy and not continuous way. We often hit many different things along the way to where we are now. I started in college in my undergraduate degree in biology and global health. So exactly what you said, Kimberly. I was really struck, I guess, by the end of my undergraduate experience. One, what do I do with a general biology degree? But second, that I had taken a class that had part of the course was focused on maternal mortality. And it was very much set across the globe, not centering the US, although we know the statistics now are much worse. But just how dangerous childbirth can be for so many women across the world. And I only have a twin sister. I don't have any other siblings. I never personally saw my mother pregnant. So I never was really connected to that. And I still can remember myself being so completely stunned by the statistics. I couldn't imagine that women go into this, life-changing process, potentially risking their lives. So for me, by the end of that process, I decided that I wanted to become a nurse because to me, nurses are the ones who are with the patients all the time and really the ones who are doing that key critical assessment at the bedside 24/7, truly. So I was fortunate to be able to become a nurse at Johns Hopkins in Baltimore, and that completely changed my life. Being up close with patients who are in just such precarious states, just again, I can't say anything else than just completely changed the way that I solve problems and the way that I address issues in the professional setting. And I sort of make the same correlate to data science, where when ultimately I ended up going to the University of Virginia in the Master's in Data Science program, and how data science really changed the way that I attack and look at problems in the same way that my nursing school experience did. But like I said, I've been a nurse for, at UVA, practicing clinically for about 7 years now, almost 8. And truly, my clinical experience has laid the foundation for my interests and questions that I have in data science. And for me, and similar to you, Amber, feeling like you needed a degree in epidemiology or data science to be able to take the next step. And that was exactly my experience as well. I felt like I couldn't answer the questions that I really wanted to without more advanced quantitative work and more like hands-on practical domain relevant skills that then I can apply to the real problems that I was experiencing at the bedside.
That is absolutely correct. And I think that's something that we noticed, and we'll talk a little bit further in the webinar about COVID. But I think that union of data and healthcare is absolutely critical for health. And again, we'll talk about that a little bit further. But now I want to leave it to see if there are any questions from any of our attendees. Please post them either in the chat or in the question and answer section, if you can access that. And about any of our backgrounds, how we got into the field, any basic questions. I can't see the chat. Can anyone see the chat? I got it. Okay, I got it now.
I do think this is a particularly interesting question about how have we gotten to where we're at, especially with data science and healthcare, because healthcare has traditionally been, or healthcare data has been so closed off to only certain types of people, right? Like we've only given access to what's happening in the hospital or in these public health settings to physicians, to higher level leadership, when in reality that real like contextualized problems come from people who are at the bedside, patients themselves, or individuals who are in these types of communities who are like deeply experiencing the problems themselves.
Okay, so it looks like we have one basic question. What is informatics? As a resident informaticist, I'll take that one. So the one question I get a lot is, what's the difference between informatics and data science? So having been a data scientist and been an informaticist, I think that informatics is more applied information that you get from data analytics or data science, right? So it's a merging of statistics, computer science, but for me, more applied, more real world, more bedside type of impact versus data science, which depending on which organization you work with, how that organization's data is structured, it could be any number of things. And I think that one of the challenges in the future for the field of data science, I think it's gonna have to kind of narrow itself down a little bit, right? Into like silos, the way engineering is, right? So when you hire an engineer, you don't say, I'll just hire an engineer. You say, I use civil engineer, mechanical, electronical. I think data science as a field is gonna benefit from that. So again, informatics, a union to me of applied real world application of what you learn from analytics combined with statistics and computer programming. Anyone want to add anything to that definition at all?
I would just like completely echo what you said. And I think especially in biomedicine, informatics and data science are very overlapping. And truly, if you're on the job market right now and you feel like you have this skill set, apply to all of them. There's going to be overlapping parts, not only in the actual technical skills that you're going to be asked to do, but also the types of problems that you would solve. So yeah, just completely echoing what you said, Kimberly.
Okay, I'm going to get one more question in here and we're going to go on. So the question is from Daria. My apologies for pronouncing your name correctly. How did you narrow down your focus to HIV or maternal mortality for the PhD? So many aspects of healthcare and data to try and narrow down. Okay, Kate, you want to talk about the mortality part, and maybe Amber and I can talk about HIV?
Absolutely. So for me, and I guess for those of you who are on the panel who are thinking maybe a PhD, I decided to get a PhD because I am deeply committed to be a professor. I want to teach, I want to mentor, and I want to be heavily committed to research. So for me, a PhD was necessary. But in terms of narrowing down to maternal and women's health, it was truly just a passion. I've been with women when they're delivering their babies. I've seen the experiences that they've had. I've been like in these very precious moments with patients where it's truly just changed my experience. And I feel like the questions that come out of that have informed my PhD work. But I would say any health applied data science right now is so important. Our fields have been really lacking advanced quantitative work. Yes, big data, and we have large data sets to analyze, great, but really taking that, as Kimberly said, turning it into insight and then developing tools centered around patients is really where we're going. So whatever interests you and whatever domain you can apply your skills to, I think the field is so open right now, but go with your gut, go with your passion, and go with the questions that you're most interested in solving.
Okay, and so as it relates to HIV, just a little bit more into my backstory. I mentioned my mother was a public health nurse. Well, she actually was one of the first epidemiologists at the health department where she worked. And so that was in the early 80s. And so that was when HIV was first starting to come onto the scene. So in high school, I did like a science project on tuberculosis. And it's interesting that I actually didn't study infectious diseases officially. I just kind of did it as a side thing, so to speak. So I actually was a HIV volunteer, again, mostly influenced by my mother. And HIV at that point was a deadly disease. We didn't have these great drug cocktails that we have right now. So it was a big disease that was starting to affect particular communities. And one of the things I like to say when you talk about infectious diseases, and this is going to go this little side step right here, is that the canary in the mine for a lot of things in society are poor and often minority communities, right? So if we're talking about the opioid epidemic, that actually was the crack epidemic back in the day. We talk about COVID-19, that actually was HIV back in the day. So I feel like the data's out there, the information out there, we're not really applying it and using it in ways to inform what we might need to do in the future. So with all of that said, I continue to volunteer as an HIV/AIDS educator throughout my career, working as a chemist. And then I finally decided when I was thinking of going into health data science from biomedical informatics, that HIV would be a great way to do it. And so I was very fortunate that I was able to work with UT Southwestern and an organization called Dallas Family Access Network. That was like one of my first data analyst positions. And it was there that I kind of started thinking about ideas about how we can do more bench to bedside with this data information that we have. And so that's what I tailored my dissertation project to. And I think we're going to talk about it a little bit more in the future. And I want to kind of keep it moving on. Thank you for the questions. We'll try to get back to all of them. Next, I think we want to talk about what are some of the tools that we use. What are the tools and hardware?
Go for it, Amber.
Sure. I can definitely speak to tools that I use on the regular. I'll say there are probably three main ones. One is SAS, which is, so if you're in FE, statistical programming is pretty much your entire life. You're trained how to do it from the time you walk into graduate school to the time you leave, and even after, and it's for a good reason. I use SAS, especially when I was doing a lot of HIV work before the pandemic. We use SAS to kind of help us get a snapshot of who is being affected by HIV. So especially within the state of Maryland, our data is used by so many different organizations and local health departments and, you know, just different groups that want to use our data to help, you know, improve healthcare, improve the availability and quality of healthcare. And so our data sets, we, you know, subset that data and we use SAS to kind of give us, you know, a better idea of, so how many people were diagnosed with HIV this year? How many of those people are from a community that's disenfranchised? How many of those people are immigrants? How many of those people are women? How did they transmit? How do they actually get, how are they exposed to HIV in the first place? All these questions can be, you know, answered using SAS. And so that's the first one. The second tool that I use on the regular would be ArcGIS. That is a geospatial analysis tool that we use to kind of get a better idea of where people living with HIV are. So like what regions have high amounts of people who are living with, you know, a certain condition. And that helps again to make care services and things more available in those, you know, areas, in those jurisdictions. Then we have Tableau, which is a data visualization tool that we've been using a lot. And that's just, I can't really ask for a better way to visualize data and make it look pretty and interesting to people who don't study this kind of thing every single day. So those three things are tools that I use and that I use them on the job regularly, and that we often get requests to, you know, show our data, you know, using one or all of those mediums. So that's what I do.
Kate, you want to go next?
Yeah, absolutely. So in my early research and dissertation period, I would say the vast majority of my programming and coding was in R, just based out of our studio, pretty basic, like traditional statistics. But my dissertation was on the biological underpinnings of gestational diabetes. So I used a lot of bioconductor packages and like standard workflows for processing genomic data. Now in my postdoc, as many people do use a postdoc to sort of pivot to a new area, I'm using, digging back into Python and TensorFlow for like the specific data that I mentioned about cardiotocography. So maternal contraction patterns and fetal heart rate during labor. But I actually want to bounce off Pierre. It's good to see you. Can't see you, but nice to know that you're chatting with us here and raising this question, because I actually think one of the biggest tools that I use is like team management software. So that's been particularly challenging, especially starting, you know, independent research during the pandemic. Is, you know, how do you manage the undergraduate research assistants and individuals who are working with you? Because I do think that having access to more data, and especially in this largely virtual setting, has created a huge need and reliance on effective team management and strategies to make sure that all voices are being heard and that we're troubleshooting effectively. So I can't say I'm using anything too unique at this point, but I just do want to highlight that there's more than just, you know, the programming tools. There are also, I love that Amber mentioned Tableau for your data visualization, but also, you know, these team management softwares and things that we're using just to help as an adjunct to making sure that our research or data projects are up and running smoothly.
Okay, so I'll round out the tools I use. I use a number of tools. Although moving into my new role as a chemical informaticist, I'll primarily be working with Python and running NLP, natural language processing. I'll also be extensively using some NCB, can't get the acronym correct, the NLM, National Library of Medicine, produces or is responsible for a number of medical vocabulary. So I'll be using RX norm and some other ones. Again, in the face of working with USP, which is, as a lot of you may know, kind of the drug standard organization for the country. Previous in my other positions, though, I've like Amber mentioned, SAS is used pretty extensively in healthcare settings. I've also used R, so my dissertation project is actually in R, although I'm now trying to become an expert Pythonista. For reasons, there's a lot of R versus Python. I say learn them both if you can, although most places usually favor one or the other. And so going into my new role, I'm going to have to beef up my Python background. But I think that there are definitely some fundamental skills I think you need to have to work in these roles. And I think one is database. So like SQL, a lot of the data that we pull from are in SQL databases. So as an example, I worked as a senior data analyst at a public hospital in the HIV clinic, and we worked with the electronic health record called Epic. So a lot of you may be aware of that. Well, the backbone of Epic are these SQL tables, tens of thousands of them, which contain patient data. So you definitely want to have some database experience and then also some statistical analysis. And so you can do that in SAS. You can actually do quite a bit in Excel. It's a little more advanced than it used to be. You can actually also do logistic regression in Excel, which I'm not sure if a lot of people know about that. Pivot tables and all that. It's a lot different than it was when it first came on the scene. And then obviously a data cleaning, data munging skill set. So you can either do that in R, you can do it in Python. So those are kind of the three, database, statistics in R, and then of course, data cleaning and munging. Now, machine learning is a whole other level. And I do for my dissertation project, I'm doing all of that in R. You can do it in SAS, you can do it in Python. There are a number of different things you can use, programming language you can use for that. So those, I think, let me talk a little bit about hardware tools, because everybody is big on MacBooks. I get it, but I don't, because I work on an HP. So a lot of what we do in healthcare works better in Windows environments. A lot of the software and a lot of things, they just work better in Windows than they do with the Mac. And because I also like Linux, I have a Linux Ubuntu on a virtual machine that I use if I'm looking, say, when I was doing genomic data analysis, I would do that, use Linux Ubuntu for that. So I definitely have a preference, and quite frankly, Apple is at the bottom of my list when it comes to hardware. You ladies have any favorites among the hardware that's out there?
I have a MacBook, but for better or for worse, I submitted long before I became interested in data science. So at some point, I think I'm going to have to either become better with the virtual machine when I need it. But for better or for worse, I am Apple.
I am attached to my iPad, but that's as far as it goes. What about you, Amber?
I am with Kate. I've got a MacBook, and I got my MacBook, I think my first year of graduate school, because I was actually in class and I was coding something using R, and I had an HP. It was like as big as my window, like a giant HP computer. And all of a sudden it just went blank and it just stopped working. And so I was like, okay, that is it. I'm sick of HP. And I went and got a MacBook. And then little did I know how much better SAS is on a PC than on a Mac. But I'm taking it as I go. It's, it's just it's a necessary evil, I guess. But yes, I am definitely using a MacBook, but I do know the joys of using SAS within HP. So
I think I would say if you're going to be a traditional data scientist, maybe not specialized in healthcare, MacBooks are fine. Not that you can't work in healthcare with it, you can, but like I said, I like Linux. And so with the Mac, I'd have to triple boot, which I don't even know that's a thing. I'd have the Mac operating system, the Linux operating system, and then Windows on a virtual. That just seems like a lot to do.
I think a big point here is one, use the tool that best fits your problem, right? Like if you are using a software that needs to or is optimized on an HP like SAS, go for it. But if you are willing to, meander and make it work on a MacBook, awesome. Right. I think especially for a lot of people starting out in this field, you don't have unlimited resources to have multiple computers and a GPU and a super cool cluster, even though you could really use it. So you have to get creative on how to answer the problems using the data that you have, in the best way that we can.
Mm-hmm. Exactly.
Good points. Okay, all right, so now let's move into some of our session questions. And the first one is going to be, what are some of the challenges and misuses of data in healthcare? Kate, you want to take that one first?
Yeah, sure. So I am going to situate this problem obviously in my domain in terms of the research that I mentioned on cardiotocography. So again, anyone who's given birth or supported someone through this process, you probably remember being hooked up to a machine in which there was a small ultrasound disc over the baby's heart, and then a second small disc at the top of the abdomen to help trace uterine contractions. And ultimately, 80% of women in the US are monitored continuously during this way through their labor process, which, as you can imagine, is extremely uncomfortable if you haven't already experienced it. But I really believe that we're using this technology as a proxy for how a mother is doing, but it's only really telling us two things. One, if the baby has a heart rate, and two, how frequently the uterus is contracting. And then with expert placement, you can get continuous readings of both. Interesting though, and I think this is true of many healthcare technologies, you can get readings that are not accurate from, say, one disc slipping where, instead of baby's heart rate, we're getting mom's heart rate. Instead of maternal contractions, we're getting her laughing or throwing up. It's registering the same signals, even though it's not actually what we're trying to assess. So I'll say that, because the data is only as reliable as the individual managing it, in this case, in my area, it's the nurse. So really the key component of listening to clinicians throughout this process, because they're really the ones who are working with it and making decisions off of it.
And but like a point to bring up the fact that, we have this idea like with autonomous vehicles that we'll be able to take the human part out. I don't actually see that working for exactly the reason you just described. I think we're always going to have some human impact in there. So while we all look at Star Trek and he has a scanner and scans the body and can, cure broken bones and stuff, I don't see that happening anytime in the near future. But, hopefully that we can advance some things, but to taking out the human component completely, I don't see that happening. Amber, you got some thoughts on that?
I do have thoughts about the part of the question that deals with misuse of data and challenges with it. So as someone who conducts surveillance, right, we get so many lab reports and we get thousands and thousands of records of all of this personal data. And I think that transparency with data collection is something that's not talked about enough. And as someone who deals with thousands of records on a regular basis, I think that it's important for the general public to know why the health department, has to get all this data. So for instance, when you have in Maryland, anyone who, is diagnosed with HIV or has an STI, all of that information gets reported to us, to the health department. And that's the law. They have to report. So hospitals, any clinic, they have to report those things to the health department. And so we get those records, we see them, and we go through a lot of, expensive training about the importance of confidentiality and minimizing or completely eradicating like the risk of data breaches and that kind of thing. And so that's one thing. So the security of data, because there are instances where things can get out and that's, absolutely horrific. But then you have transparency. So why do we need this data? And so I think it's important for transparency to exist so that, that especially in this current climate, that people won't use data to try and appeal to their own personal biases, and they won't use data, for their own kind of just personal biases. So that's really where I am with data right now, and just focusing on the importance of transparency.
I think those are some really good points. And I think with COVID, I guess we can go ahead and segue in the interest of time into COVID. Where do we start? So I'm going to speak to misuse. I think that, and I don't really know all the details. I don't think anyone, unless you're directly involved, the case of the woman in Florida, the epidemiologist who, I don't know if the story was that she wanted to report the data correctly and she was withheld from that. That's what I got from that, or that I think something else I heard was that she just disobeyed what her supervisor told her to do. And so that can be kind of a catch-22. And I'm a little familiar with that because I worked in a position earlier this year where I was looking at doing some general data analysis, right? So you get a data set, just put some quick, scatter plots together, see how things are related, just the exploratory data analysis, that's the phrase I'm looking for. So I did that. And I noticed that when I stratified by race, this was a cohort of individuals at a public hospital. So most of the patients at a public hospital are poor and or minority, but they wanted to know, where do we need to make improvements for making sure that all eligible patients receive genomic testing so that we can, cater their cancer treatment to their tumor type, okay? Ironically, this hospital that was, I don't know, over 80% minority, in the genomic studies, minorities were only represented by 10% of those who went for advanced testing. So that's a problem. And unfortunately, this is an example of misuse of data because when I presented this information, it was compressed. It was never shared with the stakeholder. That's a problem, right? Because if we talk about why health disparities exist, if you ignore the data, you're going to contribute to exacerbating the disparity. So that's kind of an example of misuse of data. But getting back to the woman in Florida, do any of you know what that story was? I want to talk a little bit about COVID because obviously it's really important. And Amber, with you being in the state health department, I'm sure you could probably give us some insight into kind of how that's going with analyzing data with COVID. And it sounds like depending on who your governor is and what party they're with, that has a lot to do with how that data is being disseminated. And then there was that block to the CDC, which I totally didn't understand. So your thoughts as a state epidemiologist?
I will say, so despite living in a state where we do have, it's again, like who your governor is often plays a part. I will say that I think the state of Maryland has done a pretty good job with how we are taking in COVID data. So a few months ago, something came out. It was some kind of report that came out that actually went into detail and said, okay, which states are reporting on disparities between, racial disparities on who is getting COVID and who is dying from COVID. And Maryland is one of those states that has that data. So if you go on our Department of Health website, you'll see a breadth of data, and it includes racial data, when it comes to COVID-19. I will say, so I do outbreak work in regards to COVID. So ever since April, I have been taking, my phone rings constantly. I have it on silent right now, but I just know that I'm missing, calls are coming in. And basically I get calls from local health departments that are reporting outbreaks to me at different facilities. These facilities are often ones where I call them, facilities where people are often overlooked, and people who are in these facilities are often forgotten. So like nursing homes, assisted living facilities, correctional facilities. And so there are so many outbreaks at these different locations. And so we kind of put data together, and we actually have it on our website, and we release it to the public. We update it every Wednesday to let everyone know, okay, so here's how many facilities in this county have, outbreaks of COVID-19. So it's something where it's in my head a good use of data, because you're really getting an idea of, okay, so what counties have, the most outbreaks, what counties, may need more services or may need help with infection control and prevention and that kind of thing. But I can say that I don't see misuses of data or anything with the work that I'm doing so far. And I'm grateful for that, very much so.
Kate, you want to add anything to that?
Yeah, I mean, I totally echo you, Kimberly. I don't know if it's the pandemic, but I have also found myself to be very pessimistic lately. I guess I generally worry about the future of data in healthcare because I think we're continuing to make conclusions based on poorly collected data, poorly interpreted data, and then subsequently building tools that only consider the patient or the individual as a mine for that data, not that they carry their own set of interpretations or experiences. And I think technologies and, definitely certain types of analyses are systematically highlighting the pervasive and implicit biases that we have, not only in clinical training, but also just generally in our society. So I'm definitely pessimistic. I think that we have a lot of smart people out there who are critically examining work that's coming out, especially around COVID, with certain treatments and protocols for how we best take care of patients. But it's a tough time to be a scientist.
It really is. And let's just say that hopefully next year at TomTom, we have a different perspective.
I will also
It'll
say
be a little different next year this time. Yeah.
Definitely hope so. And I think to a couple of the questions in the chat, I think it's especially hard to be a scientist in the COVID times, but also a female scientist, because I think, also to the story that you had mentioned, Kimberly, about the individual in Florida. I mean, I think it's already harder for women's voices to be heard in this highly technical world, but especially when we're generally underrepresented, especially as we're trying to use data in informative ways, it's especially hard. And I don't know where to take it from there.
And I want to talk a little bit more because someone asked a question about what it was like to be a woman in the field. And I just want to mention that I had a family, married and a daughter and all that great stuff. A daughter who's going to be an engineer at the end of the year. So we're going to keep that thing going. But I decided to wait until she graduated high school before I pursued my PhD. And, there are a lot of pros and cons to doing that, right? I think for me, I knew the kind of mom that I wanted to be. I was happy being a scientist, right? With my master's degree, I was very happy. Working at the National Cancer Institute, working at NIH, working at USP. I've had some really great professional experiences. But I knew that trying to balance that with the kind of wife and mother I wanted to be wasn't going to work for me. Now, that's no judgment. Everyone makes their own decisions about how involved or not involved they want to be. But I just want to mention that I made a conscious decision to wait until she got to college. And then I decided to go back to school to finish my PhD. So someone had mentioned, being a woman in the field. I think women make up 10% of data scientists or something like that. I would say that gender is by far the biggest challenge because I think what happens in data science is that it's a confluence of people from very different cultures, right? So in America, America has some challenges with, gender equity as well. But when you bring in folks that come from cultures where that's even more exacerbated, and they go into technical fields, now you have a double challenge. So now you have challenges, not just along race and gender, but along nationality. So those definitely are challenges. And so what we've tried to do, a lot of us, the three of us, I think, are pretty involved on Twitter. So if any of you are interested, you can, I think we have some information if you look on the flyer, I think, about our Twitter, I'm not sure. But at any rate, so what we do is we kind of bond with each other along similar causes. And that helps a lot. When I submitted to TomTom about this particular panel, I was very deliberate in wanting to make sure that it was majority woman representation. Now, I didn't intend for it to be all female. I had, some folks that originally was going to be in April. They changed their mind and not changed their mind, but the pandemic happened and we had to change the plan of when we would have the panel. But unfortunately, the men that I originally reached out to weren't able to do it, but I think that it's really important that we are here. We say that we're here. We aren't going anywhere, right? And that we're here to stay. Actually, we're not just going to float in and float out. We're going to work through life changes, and that we're going to stay committed to the field. And so we're just about out of time with the panel now. Ladies, you have any final comments?
I was just going to say, I really appreciate your transparency. And I think this is something that you get because you bring women together, talking about, those unique challenges. But I think especially in data science, where so many people are coming from, non-technical backgrounds, reaching into this new area is very attainable. And I would highly encourage folks who are listening to reach out to us. We'd be more than happy to talk further, but be relentless. If this is something that you're interested in, or you have a problem that you want to solve, go for it. We'll figure it out.
Okay, I just put my Twitter. That's probably the best place to get in touch with me. The one thing I do every day. If anyone has any additional questions, about how to get in the field or questions about data. Amber, you got any final thoughts?
Yes, piggybacking off what Kate said, thank you so much for having me on this panel. I really appreciate it. And also thank you for your transparency and just the questions that we got. Like there's so much I want to respond to. I'm looking down this list and like there's so much, there's not enough time. So I also would invite every last one of you to get in touch with me on Twitter. I'm on there most days of the week. I'm on there. And yeah, if you have questions, my DMs are always open, always. So yes, I just like to thank you all for coming and just for listening to me talk about EPI.